This week on the BackTable podcast.
I would just say, take a time to look and be very objective about the images and just don't let your ego get in the way. That's how you end up missing things. So I would say, take the time to write a mapping, even when you have to select and interrogate a lot of vessels. If you do it that way, it'll take you at most 2 hours.
Ladies and gentlemen, welcome to the BackTable podcast. If you're a new listener, welcome. For all of our regular listeners, welcome back and thank you for listening. You can find all previous episodes of the podcast on iTunes, Spotify, or our website, which is BackTable.com. Very easy to remember. Subscribe to the show, leave us a review, or reach out to us on social media. Now, a quick word from our sponsor. TheraSphere Y90 glass microspheres is the only FDA-approved Y90 treatment for HCC, allowing personalized and flexible dosing. An efficient and powerful HCC therapy, TheraSphere safely delivers predictable, targeted, high-dose radiation with proven patient outcomes, preserving future treatment options while minimizing the side effects. TheraSphere has over 20 years of success in HCC treatment and is backed by significant investments in clinical evidence with more than 100,000 patient treatments globally, and has the support you need to efficiently treat. Calculate your dose with confidence using Simplicity Y90, personalized dosimetry software developed exclusively for TheraSphere. Visualize prospective dose distribution and assess the absorbed dose delivered to give you optimal versatility and control. Durable outcomes, safe, reproducible results. Learn more at TheraSphere.com. And now back to the show. This is part 2 of a 2-part series. We're going to pick this conversation up that we began with Drs. Gimenez and Sandow. We're talking about Y90 and the HCC program at Ochsner. So enjoy the podcast. All right. So the patients move through clinic and you guys have settled on intraarterial therapy. I'll leave it up to you guys how you want to split it. I'd like to talk about radiation segmentectomy, but also what patients end up with lobar treatment and how you choose between those two. Is there a number cutoff, a volume cutoff? I mean, it's a big topic, but I'll kind of let you guys chew on it.
I'll take the rad seg when that's the easier one. I'm joking.
Yeah.
We were talking about the outline before we got to it. And, we got to the bullet point that said lobar treatment, and we both looked at each other and said, what is that? We typically don't do that. We're not saying that there's not a place for it or it's inappropriate. It's just that in our practice, we tend to select everything out and go after every little feeder for the tumor. So sometimes that's 4 or 5 different vials. It's a lot of cone beam CT. We not just looked at our data, but published data. We know that what's important is not the grade or the amount of radiation, but the amount of liver you're putting that radiation on. So if you put in,
that's when it comes to adverse events, I think you're trying to say.
Yeah. So, we try to keep our volume small. We select everything out, and that's our philosophy. And that's what's worked for us the best, And sometimes, in order to be able to achieve that, we have to use a combination of ablation and Y90, depending on size and location, all these other things. Tyler, what would you add?
Well, I would say we try to make everyone a rad seg candidate, even if it's a multifocal disease that has tumors. And say you have 4 or 5 tumors, we honestly will try to make you a rad seg candidate. And so we might not all do all the deliveries in one setting. We might split them up, do 2 on one day and maybe 3 on another day. But even if it's metastatic disease, we try to make everyone a rad seg patient. So we don't do a whole lot of lobar. One can do tons of fancy multi-compartment when it comes to larger volumes of liver that we treat. And he's way smarter than me when it comes to basically anything that's to do with Y90. But I like to keep it as simple as possible. I try to make everyone a uni-compartment rad seg, and it has worked well for me.
All right. So this is actually one of the really core principles that I kind of wanted to get at. And I don't want to gloss over it and you just say, oh, okay, everyone we try and make into a rad seg. There are a lot of practices out there, advanced practices that are not like that. Can you kind of talk about how you got here? What are the challenges involved in trying to get into all these feeders? How long do mappings take? Just the nuts and bolts of actually making this a reality.
Well, so we have something called the sphere conundrum, but you told me that you were going to cut me off if I talk about it for too long. And so
I tried. I thought I took that out of the. So I have like the outline that I send you guys and the outline that I make for myself. I guess I left it in there. But
so I got the sphere conundrum, and I can blast. I can dig deep down into a hole. If you give me 3 minutes, 5 minutes, maybe I can probably.
Let's hear it.
Let's hear it. Do you want to do it now? I mean, we can.
Yeah, let's do it.
All right.
Perfect timing.
Should we do this now, Juan, or is there a better
just
time?
Doing that, you touch based on that because it'll explain everything as far as our philosophy. I can take it on the back end and answer your question about length of mapping because it's not as long as you would think it is.
Right. Okay.
All right. So Juan will go through our technique, and I think that's important. But I think we have to understand at the most granular level why Y90 works. And so Y90 works because beta decay results in a release of high energy electrons, and that essentially becomes microscopic bullets. And that's what damages tumor DNA. Now, you damage tumor DNA one of two ways. You either create a double-stranded break. If you get that, that's the headshot, right? That's going to kill them instantaneously. Alternatively, you get a bunch of body hits, right? Single-stranded DNA hits. Well, some DNA can fix those. So you have to accumulate multiple single-stranded hits or multiple body hits to kill a tumor cell. Now, most people would agree that 1 cc of tumor contains about 1 billion tumor cells. So you need either 1 billion perfect hits or some higher multiple of that to kill 1 billion cells. Y90 is a game of statistics. So the goal is to get your activity up. And this is why Legacy was so successful if you compare it to everything else. So Legacy showed that you had higher rates of CPN with doses greater than 400 gray. And that's different than what people used to think of when we were talking about 190 or 200 gray, right? What the difference with Legacy was the activity was doubled, right? So you have more bullets are released essentially. So then it becomes a concept, or I guess now let's look at sphere activity and dose. So if we talk about a TheraSphere sphere, like a microsphere that was delivered at week 1 Friday at noon. So I guess that's 6 days after calibration. That sphere is 1175. The mean activity of that sphere is 1175 becquerel. You compare that to a sphere that has much less energy, like a 168 sphere, something that would be delivered on the very, very back end of a TheraSphere model. So week 2 Friday, or a 168 sphere is a Flex 3. All right. So an 1175 becquerel sphere will undergo approximately 330 million decays in 1 week. Now, a 168 becquerel sphere will undergo 47 million decays in a week. That's a difference of 250 million decays, right? So it's a massive difference in the amount of bullets that are released. All right. We know space is limited. So if there's already 1 billion tumor cells in 1 ml of tissue, do I want to pack particles in there until they're in enough space, or do I want to make sure activity is in there to do what it needs to do? So it becomes a concept of the sphere conundrum, right? So if I had an 1175 becquerel sphere and I needed to get 400 gray, and you need about 7,000 spheres. If I had a 168 becquerel sphere and I needed to get 400 gray, and you need about 50,000 spheres. So we looked at our results, and we looked at our SPECT CTs and our post-treatment imaging, and we could kind of figure out exactly how many spheres went into these tumors. And we rarely got over 20,000 spheres into tumor, even at the most smallest of volumes and highest of concentrations. So if we use 20,000 spheres as a cutoff for what we would call difficult or undesired saturation, and you wanted to get 400 gray in to the tumor, you need a sphere that is about 412 becquerels worth of activity. And that's equivalent to about 8.5 days from calibration. So delivering on a week 1 Monday or week 2 Monday or early week 2 Tuesday. If you look at Bo's data, where he actually looked at specific activity, he came to the exact same conclusion, right? That you need to be delivering high activity spheres to get higher rates of CPN. And he said you shouldn't deliver more than 8 days after calibration, which would be week 2 Monday. So for that reason, we treat almost all of our patients week 1 with week 1 vials, because we know that that activity gets to the tumor the way we want it to. And I'll end it with this, and I think it sums it up nicely. You look at the studies that actually talk about durable outcomes, or CPN, Legacy, Razor, dosisphere, Target, the Mayo Clinic data. I like to call them Bo 1 and Bo 2. These all used high activity TheraSphere doses. These guys, the majority of the people that publish these results are week 1 TheraSphere users. And so if they're getting durable outcomes doing rad-seg like that. I think that's the way that we at Ochsner have found that we can replicate what they do. And our outcomes have ironically replicated everything that they've done. All right. I think that was...
Or non-ironically.
Was that...
Okay.
Yeah, non-ironically, I guess.
Minutes.
But was it 5 minutes? Did I do it?
Good. That was right on. That was right on.
All right. You can cut me off. I don't need to talk anymore. I did all I needed to do.
I do want to say something, and I hope this makes it on the final version. Tyler said that I was smarter than him. There's no way I can come up with what he said. He was just doing that math and talking about millions and billions of numbers. I'm not that smart. I just letting you know right now. I'm simple guy.
We'll make sure it gets in there, Juan. All right, Juan, can you kind of digest some of that and talk about how the SPHERE conundrum ultimately leads to how you guys approach, I guess like the take home is hotter spheres, week 1 dosing, and what you've already said is that you select out for individual feeders and so you're trying to do rad-segs. But just expound on that a little bit.
So Tyler said high specific activity matters. We do believe that. The only way to do that is to treat as close to day of calibration, which is on a Sunday, as you can. The problem with that is with increased specific activity, your dose goes up too. So, then you have to make sure that you minimize adverse events. The only way that you can minimize adverse events is by treating as small amount of liver as possible to take care of the tumor. Otherwise, you're going to end up with a lot of specific activity, a high dose in a big volume. That's what's been shown in all these studies, like Target, for example. And both has some articles too, showing that it's about the size, the amount of normal liver that you treat that results in complications, not necessarily the dose. So when you put all of that together, then you're basically left out. It's like, we need activity, we need dose, we got to stay safe. The only way to achieve all those three is by getting as selective as you can. So then you have to go fish all these little vessels out, to a point as to you got to do all these things. Your mapping has to take 5 hours. We boiled down our technique literally, and it's not hours. There's 3 papers that pretty much summarize everything that we do. And it's not my idea. So like I said, I'm not that smart, but I'm a great copycat. But no, for real. So one of them is Ron Gava's paper. There's an ACR, NSM, and Society of Nuclear Medicine consensus paper. And then there are the consensus guidelines for dosimetry that the most updated one are from 2022. So basically, those 3 papers together is what we use. Mapping is simple. If you just think what the purpose of the mapping is, then you can understand what is it that you need to do to get it right. So basically, the purpose of a mapping is to identify all tumor feeders, vessels that are going outside the liver, any potential extrahepatic supply. So with that being said, literally ours is a protocol. So you have to always restart by reviewing your imaging, try to identify any variant anatomy, then stick to it. Power runs, key. No matter how strong you are, you're not going to be able to inject 5 for 30. You can't do that. So power runs. Start with a celiac, if needed, do an SMA, and then go from big to small, either common or proper hepatic. Do we do this for absolutely every treatment? Now, if you only have left-sided tumors, just go into the left. If it's only right. If you have somebody between, segment 4, segments 5, 8, you have to interrogate both the left and the right, because invariably you will have feeders from both. And then cone beam. Cone beam CT is the mainstay of our practice. So, and again, it's the same concept. Start big, so do a lobar, and then get smaller. Start getting selective and more selective until you make sure that you get what you need. What people tend to say, Y90 doesn't work or have a residual. Wherever you deposit the radiation, it will kill that tissue, whether it's liver, stomach, heart, esophagus, it doesn't matter. But it goes in there, you're going to end up with a hole. So whenever you have some leftover, or like some residual, it's not because the radiation didn't work, it's because you don't put radiation there. So that's why the concept of do a lower spin and then get smaller and make sure you have complete coverage is extremely important. I will tell you, we use a lot of 2.0 French microcatheters for deliveries. A lot of times we will not select those arteries during mapping because they can get spasm or they can get dissected, and then you're not going to be able to treat. But you have to be able to identify knowing that will introduce an unknown at the time of delivery, right? Because then you might have to spend a little bit of time. But then identify everything. You may have bilobar disease. Take the time to do it and just follow that big to small approach, right? So if you're on the right lobe, start with the right, come in on the right, anterior division, posterior division, 5-8, 6-7, and cone beam all of those things and get smaller. And then I would just say, take a time to look and be very objective about the images and just don't let your ego get in the way. That's how you end up missing things. So I would say, take the time to write a mapping, even when you have to select and interrogate a lot of vessels. If you do it that way, it'll take you at most 2 hours. Now, when a mapping takes 4 to 5 hours, so when you do the complete opposite, so when you say, oh, there's a lesion in segment 2, I'm going to go to segment 2, and then you don't see anything. So then you start backtracking, and basically you end up higher radiation doses, more time, more spins, more of everything. So start big and go small. Saves you time. Literally, everybody that comes through our practice, all our trainees, that's how we tell them how to do it. And if you, ourselves included, deviate from that, we pay the price for it. Then just come up with a treatment plan. Do it all at once and then decide. If you know that, you have to treat 4 or 5 vessels, sometimes, it'll be easy. That can take you about an hour. But if you're sub-selecting multiple tiny branches, 2 of French, very tortuous anatomy, divide it. Just do 2 at a time. Don't get mentally exhausted and then give up. So just do 2, bring them back 2 weeks later, do the other 2, and then just get your imaging. So we've learned from our own mistakes. I said our technique has evolved significantly since we first started doing this. And as of today, I can tell you that's what works best for us. And that's what has allowed us to replicate the results of, some like Tyler likes to call them the 190 giants. And I agree with them, of these guys. But it's just having, being very methodical and paying a lot of attention to detail.
So there's like a lot of questions that I wanted to dig in on that. But one of the things that strikes me is complete coverage of tumor. So if you're going and subselecting each vessel, like the way I kind of think about it, like when ablation is you want to hit the tumor, you also want to hit the margins around the tumor. Is that a consideration? Like whenever you're treating?
Yeah, you'll always have a margin, right? It's unlike I would say ablation, which you can get very, just to a tumor and ablate that space if you want. If you think of, vascular territories, they're always going to be like angiosomes, that's a term Bo likes to use, and triangular in shape, right? So you're always going to have a little bit of a margin. What we see the biggest issues is like you miss one of the part of the tumor. And so I'm not talking about like a centimeter, it's a couple of millimeters. And that's where the lobar cone beam is so important, because on that lobar cone beam, it has multiple things. So you can see the entire enhancement pattern of that tumor. So if you get too selective and you miss something, also if you do a right lobar and you don't see complete enhancement, you know that you may have to go to the left, or you have a phrenic or something else going in there that you have to look up, you have to look for. So that's where the issue comes. So you're always going to get a margin no matter how selective you are. At least that's been our experience, because there's always a little bit of normal tissue. But the most important thing is the more selective you get, you may just stop isolating other branches that may supply that you may miss. And I can tell you, it's very easy to do if you just go straight to a vessel and you see a nice round enhancement area, like, oh, I got it all. And then you go look back and I'm like, oh yeah, I guess I missed this little edge.
I see. And you also talked about the MAA delivery. Sometimes, where exactly do you put the MAA if you're not always going to, I guess like I've always thought about like putting the MAA exactly to like mimic the actual treatment dose.
We've used to do that. You'll hear people tell you that sometimes if you do it too selectively, you can occlude that vessel. It's happened to us a couple of times. To me, 1 or 2 times is more than enough to want to change my practice, because you can't treat that patient. So we tend to do the majority of our MAAs lobar. And in that way, you just get a good understanding of everything, and you avoid any potential occlusion.
Well, so the caveat I would add to that, where we talk about MAA, is, and Juan does this much better than anyone, but whenever it comes to multi-compartment, when we do a multi-compartment or partition dosimetry, I think if we're going to treat a larger volume, that's where we care if that MAA is actually delivered close. Because sometimes, not all the time, but sometimes MAA will behave like you would expect the particle to behave. And if it does, you have a great way to kind of anticipate how your dose will be delivered. So when we're planning to do multi-compartment, which again is a rare part of our practice, or at least mine, if we plan to do multi-compartment, we care where the MAA gets delivered. We might deliver it in a division or in a large portion of a segment. But otherwise, if it's just going to be a uni-lobar segment or a uni-compartment segmentectomy, it's going to be a lobar delivery or a lobar MAA.
Do you guys use any of the software, software that like OncoSuite that helps you select the feeders or
to select feeders? No, we have navigation software with Siemens, like InvoGuide, we don't use it routinely. I will say, to plug Juan on this cone beam CT thing, he's a big advocate for lobar cone beam. And then what he does, and I think we all should do, he goes back after his mappings and will confirm that he completely covered the tumor in the same way with all of his segmental or subsegmental cone beams. He will confirm that he had complete coverage of the tumor, and he actually overlays them to make sure that he had everything laid out well. I think that's the only way to make sure that you covered it and you aren't going to be surprised about any bad responses or suboptimal responses. We do use dosimetry software, though.
Well, hold on. Before we get to the dosimetry software, which I do want to talk about, I wanted to talk about how you guys calculate your volumes. Are the volumes of tumor treated are based off, do you use it off the old cross-sectional, or can you just calculate it off the cone beam?
We love to use cone beam.
Yeah, cone beam.
Cone beam.
Everything straight from cone beam.
All right, so now I do want to talk about dosimetry. Do you guys have some software that you like that's been helpful or kind of been an unlock to how you treat these guys?
We do.
Yeah, we're biased.
A little. Only it was forced on me. I should say that dosimetry software was forced. I wasn't always this way, but I have come to be a believer. Before, we used to use the TWI Excel spreadsheet that a lot of people use for TheraSphere. And it worked well for us. We had no issues. I absolutely hated the way we had to draw volumes. We had what was the name of it was a Vital product that we had to use. Vitrea. Yeah, we had to use Vitrea to map out our cone beam volumes. And it took forever. It was probably one of the most challenging products to use. And then we switched over to MIM. And MIM is okay. I don't love it. I don't hate it, but it's just okay. And Murata had kind of, I think Juan has been working with them for quite some time, and we had a lot of case volume, and Juan had a lot of interest in dosimetry. And so he's been kind of working to refine simplicity for quite some time. So he actually pushed me to start using it. And I will say that I didn't really like switching from what I'm used to with the Excel spreadsheet, which was working fine. But I do believe in the simplicity. It has allowed us to up our game when it comes to multi-compartment, when it comes to looking at post-treatment spec and making sure you can do voxel-based dosimetry. So we know what our D70 looks like, the dose to 70% of the tumor, or D99. A lot of the stuff that we've been able to do with simplicity has been great. So it's made ordering smoother. And I think I should also plug Juan too. Juan is actually setting up a course. He's got a simplicity course coming up. I saw
it on the SIR forum.
Did you see it? Yeah.
You're making me blush, Tyler.
I know, man. Juan is going places. I don't know if you realize this, but you better get on board now. Juan is there, man.
Yeah. I feel like a rocket ship is like in the room.
Exactly.
Because of Tyler.
No.
Yeah. All right. So simplicity, that's the Boston Sci product?
Yes.
Like the software. When did you guys start using it? What do you like about it?
So we started using it around COVID. So to Tyler's point, we had been working with Boston and they had this new product. I think Boston understood that the whole ordering process and the dosimetry process was cumbersome. Nobody was really doing it. Even MIM didn't have a dedicated software for Y90 at that point. So we had a lot of headaches. We were switching packs, and with the switch of the packs, our volume software went away. So we needed to do it. And, so we brought it in. It is, like its name implies, it's simple to use. But at the same time, it allows you to get as granular as you want. So you can, to Tyler's point, draw all your tumors, look at how much radiation went to each of them, and get as granular as you want. But it's something that, we have some of the guys in our group have difficulty using computers, and some are very advanced. And this catered to pretty much everybody, right? I could just show and they can just do it themselves. So it was very It was very easy. It allowed everybody to keep their ordering on time, because otherwise people would just procrastinate. It helps us keep a huge database of all our patients. They're all saved, so we can go and literally open any of them. It's been key to look at our outcomes and research and a lot of the things that we've been doing with what Tyler's been doing, I should say. I just write his coattails when it comes to all of the research stuff. But yeah, it's simple. We have 4 or 5 vial cases routinely. I would say if we get one patient with 1 vial, that's like unheard of. So, when you're ordering multiple vials, to be able to understand how much you're going to send to the lungs, how much you're putting into the liver, the percentage of the liver that you're treating, that makes it very simple. And to Tyler's point, MIM works. It's just that there's this thing about MIM that they like to make it a little bit complex, and it's unintuitive in my opinion. I was not able to figure it out. So, and now all the nuclear medicine guys love MIM. So more power to them.
So what do you guys use Symplicity for? As far as, Tyler, you mentioned you guys do specs on the back end after treatments to look at dose and where it's going?
Yeah, we do specs after spec CT after mapping and after delivery. That's the Juan protocol, and he has made sure that where we do Y90, we do spec CT. And I think that's a good thing to do. Not everybody has access to spec CT, but we do, and we're going to make sure that we do it that way. So if we're going to do multi-compartment, we'll use the mapping spec CT if it can help give us kind of an idea about dose to tumor, dose to normal, and we can tailor our dose that way. And then we'll also use Symplicity, the actual dosimetry aspect of Symplicity, to track what the dose to tumor was and actually look at, and you can take it even more granular, right? Do voxel-based dosimetry. They call it D70 or D50 or D99. You can see what the dose to 70% of the tumor or 90% of the tumor, or what your dose to normal was. And we'll use that. And that information is that detailed information has allowed us to figure out how spheres were deposited in tumors, right? Because if we know what the dose was in those areas based on the spec CT, we know how many spheres went there if we know when we delivered the spheres. And so we've been able to figure out sphere concentrations in normal tissue and tumor tissue and kind of optimize how we choose what day to deliver particles.
So we've kind of talked about it in a roundabout way as far as you guys try and get selective as possible, high dose matters, like as far as like hitting 400 gray. Can you get a little bit more specific about when you're ordering your dose? So you already know the volume that you're going to be treating. You want to minimize or keep the volumes as low as possible. But when you're dosing these patients, you care necessarily if it's 500 gray, 600 gray, or do you just try and pick a vial that is going to be above 400?
Dead is dead.
Yeah. And I would say our baseline is 400s. There's a little bit of caveats to that, but, we've gone as high as over 1,000 gray to perfuse volumes and tumors. Granted, small volumes, right? Putting 1,000 gray in like a 300 to 400 cc volume, that's dangerous. So small volumes, yeah. And then I guess the biggest caveat that we notice that we try to be careful is close to a porta hepatis and that common bile duct, because you may get some issues with the bile duct and then you end up with strictures and they need biliary drain. So I would say close to the hilum, be a little bit careful. But if you're peripheral, right there next to a gallbladder, it doesn't matter. Tyler has a case like he shows all the time, 1,200 gray, segment 5, that right there next to a gallbladder, nothing happened to it. With that next to the colon, next to the stomach. And we have not seen any complications from the procedure itself. It's not an issue for transplant, according to our transplant surgeon. We have been told sometimes if you're going to go to resection, not necessarily transplant, there may be some adhesions that may make the operation a little bit more complex. But yeah, we'll just say 400. And then we do follow the dosing recommendations from the consensus guidelines. So if you look through all of those, most of this comes from a dosisphere, they'll tell you that you need to put at least 205 to 2 more, preferably 250 to 300. So we try to follow that as our, lower end of radiation. So if we cannot get that much into tumor, then we might have to switch to a different modality. But using 200, even close to that porta hepatis region, has been safe for us.
Okay. So does this mean everyone is week 1, Wednesday, Thursday, Friday treatment? Or virtually?
Just about. Now, we will occasionally, so If you're treating really, really small volumes, like let's say if you're only treating 25 mLs worth of volume and you put in the smallest file size you can get is a 3GPQ, and you're going to put that in 25 mLs worth of tissue, that's going to be close to, I'm trying to think, spitball it. I think it's 1200 gray. And now talking to people, and you never know who will be you're talking to about this. 1200 gray can make people nervous, right? Because they just associate gray with like, oh, that's too hot. I'm going to like cook my hands on it or something. Granted, dead is dead, right? If it was going to be dead at 400, it's going to be dead at 1200. Really, dead is dead. And so that I like to come back to that whenever we're talking about radiation delivery, but occasionally, rarely we'll deviate into like a week 2 Monday, especially if it's a small volume and we want to keep our radiation like in the porta hepatis region. We want to keep our actual gray low, like in the 250, 200 range. So we'll deviate a little bit, but I would say again, 90 to 95% of our deliveries are in that week 1 Wednesday to Friday range.
So there's another scenario that I wanted to get at. Some of what we talked about is like the tumors that you can just dunk all over, like the ones where you can get like and achieve like a 25 ml volume. But what about if like you have like a centrally located, maybe away from the porta hepatis, but big tumor, centrally located, multiple feeders? How do you tackle it?
We are cone beam crazy. And our team expects us to do cone beams, and we go in there with the anticipation we will cover every possible feeder. And I think there's multiple ways to do this. And I don't disagree with the philosophies. Our practice, we want to make it subsegmentectomy because we know that if we can maximize dose to tumor and limit dose to normal, we have a better opportunity to come back on the back end, right? If we don't perfuse the whole liver with dose, even though the majority of it might get sucked up into tumor, we have an opportunity. And an 8-9 centimeter tumor, we might be coming back to retreat them. I think another school of thought is to do a larger volume, knowing that the tumor is going to soak up the majority of the tumor. You can either do a partition or multi-compartment dosimetry for it, or you just do a lobar dose, maybe at 200, 150 gray, knowing the tumor is going to take a dramatic more amount of those spheres, but you're probably going to be coming back. And so I think both ways hold merit, but our practice is we will select every feeder. If it's 7 feeders, we'll do it. And that's the detail that I think we like to push for, because we're competing with surg-oncs for cases, right? Like, and I shouldn't say we compete. We share cases and we do what's best for patients. But in the real world, surg-onc, they're going to take the time to dissect out and make sure that they carve a margin on a tumor. And those cases might take some time. So I feel like if we're trying to produce the same results as our colleagues in other specialties, we owe it to the patients to spend that much time trying to select this stuff out.
So how about tough locations? Like we talked about centrally located tumors, but what about tumors that are, well, wherever they are, they end up like having some extrahepatic feeders? How do you guys deal with that?
So we map them out, and then it goes back to the same. You got to understand what you're dealing with. Have we done extrahepatic? Yes, we've done a couple of phrenics, adrenals, even gastric branches, GDA branches. I think Tyler's done splenic branches. The key thing there is just to make sure that you can control where the radiation is going to go so the liver is low. That might be one of the instances, if we're doing extrahepatic, that we may put the MAA there just to be 100% sure that we don't have any distribution that we may not be able to account for. And then we infuse a little bit slower and we dose a little bit lower. I would just tell you, with anything that may be going to a bowel, the number one thing is just to make sure that you're not going to get anything in the bowel. And you can still go pretty hot. With some of the other things that may be going to skin and diaphragm, particularly skin, you have to be careful because you may cause radiation burns and they may end up getting wounds and things like that. I think there's been case reports of people inadvertently putting Y90 into the falciform artery and they end up with like skin burns. So toning it down, making sure that you understand where everything is going to go, and try to get selective. You'll see even with some of these phrenic branches that sometimes it'll be one dominant one that'll just go to tumor. So get into that. And I would say treat everything that it's fed by the liver first, just because that's going to be safe. And sometimes you'll get a little bit of an unexpected result from that extrahepatic. Fortunately, you'll see that some of that will respond to treatment and can't really explain why, but I've had that happen. So always treat the liver first and then just take the time to analyze. If you're going to hurt skin, taste, maybe you can ablate that component. So be open to other things. But But yeah, you can do it. It's just you have to pay attention. I would say don't go trying to do that on your first case or your first 10, 20 cases. Maybe give yourself a little bit of time to get comfortable with everything.
Get your chutzpah, sure. So how many vessels do you guys, or is coiling a part of your practice for the mapping part of the procedure if you're trying to redistribute flow or just exclude like branches that you're not sure if you're going to get reflux into?
I would say for reflex purposes, no. If we have to, we'll just get more distal and split doses. Now, redistribution, it's a concept that I understand. I think it works great for some people. I have not been successful in making it work the way I wanted it or reproducible every time. So I don't use it. I don't do it for that.
Okay. Tyler?
Well, I have a technique called the Sandow spasm. Sometimes it happens in the tumor vessel. Sometimes it happens in the normal vessel. What I try to do is I always try to, if I want to redistribute flow, I try to spasm the normal vessel. It works sometimes, it doesn't work other times. And sometimes what'll happen is I'll spend a couple minutes trying to spasm a normal vessel and gently select the tumor vessel, and the tumor vessel shuts down on me and the normal vessel looks beautiful. So we'll play with that. But I same kind of concept as Juan. I'll occasionally coil, if it's a falciform artery or something and it's huge, I'll coil. But I really love putting ice packs around people's belly button. That's my thing.
Okay, fair enough. Let's see. Is there anything that I didn't cover in terms of y'all's mapping, treatment, dosimetry? I mean, we talked a little bit about unicompartment and multi-compartment. I feel like y'all referenced multi-compartment a couple of times, but I think you said earlier that 95% of the time you're doing unicompartment.
Yeah, it's just because we're doing multiple segmentectomies. It's easy, it's to the point. The biggest thing with multi-compartment dosimetry is that you need very good distribution of your MAA. So if for whatever reason it clumped or something happened and it's clutchy, and it doesn't correlate with tumors, you can't use it. So we just say, if we have somebody that has like those BCLCBs with multiple tumors everywhere, and then you're looking at doing a lobar or a pretty large amount of liver, and you may have to come back, then yeah, definitely do a multi-compartment. And rather than dose into tumor, dose into normal parenchyma to stay safe, then that's when we would use it. But the majority of our cases truly are, tend to be either advanced or bigger tumors. We get segmentectomy. So everything is just teasing out as much as we can and delivering into a smaller volume.
Okay. Speaking of like tough scenarios, as far as underlying liver disease, do you guys have a cutoff for how much volume you want to preserve depending on if they're child's pew A, B, and C, or each patient's individual and you just have to case-by-case basis?
I think we look at it on a case-by-case basis and a situational basis. I think if we know that we always have transplant as a background option for the patient, we feel more comfortable being aggressive because we know that should we run into problems, we do have an option for liver failure should we progress. Juan, I should say, he pushes this on everybody, but we look at bilirubin and a trend in bilirubin more so than we look at a number. And we use direct bilirubin too, right? So if someone comes in, and it's not just about their child pew class, but we pay more attention to albumin and bilirubin independently, one as an anticipation for outcomes and one as an anticipation for adverse events. So bilirubin is our key metric for adverse events. If they come in with the bilirubin that is 1.5, most people would say if it's a small segmentectomy, we're going to do fine. But if the bilirubin was 0.5 3 weeks ago, we might pay a little bit more closer attention to that because they're kind of in a trend of liver decompensation. And we don't want to be the kick into a full-on liver failure. So we look at trends. I should say, we follow the data. Bo has published a great paper talking about in patients with compensated liver function, you don't really have to pay attention to volume. In patients with some underlying liver dysfunction, ALB2s, child pew Bs, you need to be treating less than 15% of the total liver. And that's kind of where we are. So we try to keep the total volume of liver that we treat with segmentectomies in just about anyone, normal, abnormal, less than 20% for anyone. If it's going to be a segmentectomy dose, and we'll split. If it's going to be more than 20%, we'll split doses. We'll bring them back and maybe treat another, get 15, 20%, and then bring them back and treat a little bit more, make sure that the liver is holding steady.
How far do you wait between treatments?
3 to 4 weeks, 2, 3, 4 weeks. and we'll track we'll get a bilirubin at whatever that midpoint is, because that's another metric in time. And then we get a bilirubin on the day of treatment. And as long as those are holding steady, then we know we're pretty good. But obviously in patients with liver dysfunction, we don't want to treat more than 15%, and we'll try to treat even less than that. And that's why subsegmentectomies have really worked for us, because our treatment volumes are so small compared to the total liver volume that we can get away with a lot.
Okay. So switching gears, like left turn a little bit, research you guys are doing. Are you all publishing any of this? Is this,
That's all Tyler.
Ochsner secrets? Like,
yeah, we like to keep it, we hold our cards close. No, I have zero academic time. And so basically, if anyone from Ochsner administration hears this, maybe they'll give me some. No, we work with some of the most brilliant research. We have a research team that works with transplant and has agreed to partner with us. And so Paul Thibodeau, Kelly Nunez, they have kind of built-in protocols and algorithms for tracking these patients. And that has gained the interest of a lot of companies, even outside of the local regional spectrum, but just in the HCC spectrum as a whole. One of the coolest things and we're in the process of publishing a lot of this stuff. In the last several years, we put out about 3 or 4 or 5 papers a year with our group. The coolest stuff that we have coming down the pipeline is we're looking at tumor markers, and tumor markers that aren't readily available in the US. They are available in China and they've been used for a while, but they're not really pushed in the US. What we've identified is there's 3 tumor markers, one of them being AFP, but the other 2 are not routinely ordered. And what we found is that if you have multiple biomarkers that are positive, your tumor tends to behave incredibly aggressive. If you have biomarkers that are negative, you basically could flick the tumor and it's going to die. But if you have 3 that are positive, you got to throw the kitchen sink at it. And even if you throw the kitchen sink at it, you rarely get on top of it and get control. And so we have Kaplan-Meier curves kind of showing how that lays out. And I have never seen Kaplan-Meier curves look as beautiful as this. I mean, like it literally follows how you...
It's a nice Kaplan-Meier curve.
Yeah, I was like shocked. So tumor markers is a big thing. Another thing that we're looking at, and that we mentioned earlier, how we kind of deviate off the BCLC spectrum, is albumin. And we use albumin as a marker for tumor response. We can get on the nitty gritty, but albumin is kind of a marker of nutrition. Nutrition is a marker of immune function, and all those key concepts tie into tumor response, right? If you have good immune function, the body can help compensate and take some of that tumor down. So we've looked at maybe 500 patients, and ideal patients, if you stack apples to apples or even apples to oranges. What we found is that there was an unusual situation with our ablation patients. And so our ablation patients, when they had low albumin, so an albumin 3.4 or less, they tended to have higher rates of recurrence at 1 year and at 2 years compared to any other modality, intraarterial, TACE, or Y90. And so we kind of did a deep dive on it. We're like, oh, so the first question you would ask is maybe VJ left and you guys just became bad ablationists, right? Like that would be the first thing you would say, right? He gets involved in this data too. But ironically, if you have an albumin greater than 3.4, you almost have no progression after ablation. But with our Y90 population, we have almost no progression at 2 years, or any intraarterial therapy, no progression. And so we're going to study that a little closer now. But for patients that would otherwise be candidates for ablation, if you have an albumin less than 3.4, we're actually choosing to treat those patients with Y90 because of the results that we've seen over the last several years with the ablation patients.
Very nice. Is there anything like I didn't bring up that I glossed over as far as like the Ochsner way for treating HCC that was kind of a gaffe? Like, is there anything that we need to go back and cover?
I think there's, we could talk about combination
therapies.
Our oncologist, in combination with systemic too, I think.
Okay. If
we can partner up, 2 heads are better than 1. So we try to, especially for those infiltrative tumors or those huge 8 centimeter, 9 centimeter tumors that might not make it to transplant or certainly going to sit on the wait list for a long time. We try to get oncology involved readily. And we actually refer patients to oncology just as they would refer patients to us. It's a shared partnership in outcomes. And I find that if we combine our treatments, we tend to have incredible results.
Are the oncologists asking for biopsies, or they'll still treat LIRAD 4 or 5?
No, our oncologist, if it meets imaging criteria for HCC and the AFP is elevated, or even if the AFP is elevated or not, But if it meets imaging criteria for HCC, they are comfortable going for systemic immunotherapy too. I shouldn't just say systemic, it's immunotherapy.
Okay. Yeah. So actually, that was my next question. Are they actually getting like sorafenib, or is it mostly they're getting immunotherapy?
So it's immunotherapy. We will either do the stride regimen or atezo-bev. And if we're going to treat with Y90, we're going to hold the bev, the Avastin, or if it's stride, we'll try to go. But we tend to we'll map and treat while they're on immuno. Anecdotally, I think we tend to see immunotherapy responses after the second cycle. So within 1 month of starting immunotherapy, because they're biweekly. So by 2 cycles, you probably will see what immunotherapy is going to do. But Y90 has either been used to clean up what residual we see with immuno, or we'll hit it first and let immuno kind of be there to sit and hold it. So get a great response and no progression.
Very cool. Juan, anything else that I didn't talk about?
No, I think you did a pretty good job. Covered pretty much everything. I'm glad Tyler brought up that systemic combo aspect of our practice, because it's grown a lot over the last couple of years. And the one thing I want to let people know is, like, typically you think of your multidisciplinary conferences. We don't think about them this way, but you may think that the more players you have, the less chance of getting referrals and things like that. Ultimately, what we realize is the more people that you have on all your multidisciplinary conferences, you end up capturing more patients. And otherwise, you're going to get patients that you may not have the best option for, but because you didn't have maybe an oncologist or a surgical oncologist or a transplant surgeon as part of your team, you may not be able to refer to them. It has allowed us literally to all work together. And, sometimes they'll get resection and we come back and do lobectomies, or we'll do, embolization. Same thing to Tyler's point, working with oncology at the same time, or coming after them, or them coming after us. As patients progress, sometimes it's been extremely helpful, and our results as a team have gotten better.
That's good. Anything you guys are excited about as far as like things that are coming down the pipeline, or things that y'all are doing with your practice, whether it's HCC or something else that you want to talk about? Final thoughts.
You didn't put that one on the outline. Now I got to think about it.
No, I didn't, man. It's got to be some kind of spontaneity.
I think we're starting to see segmentectomy play a role as an ablative modality for metastatic disease. And I think we always used to think of Y90 as a lobar only treatment for metastatic disease, right? Whether it be trying to control multifocal or microscopic disease that you couldn't see. And at least what I'm seeing is that the paradigm seems to be shifting. There seems to be more of a push for us surgeons, anyone, to be more aggressive in controlling tumor burden, especially inside the liver. So we're using the segmentectomy game to our advantage. We'll do multiple subsegmentectomies for multiple metastatic tumors, kind of applying the same concept among the sphere conundrum thing to our practice. And I think we're going to start to see Y90 reemerge as a treatment for metastatic disease, but it's going to be Y90 as a ablative modality, similar to what you see with microwave ablation or RFA when it comes to treating metastatic tumors.
I'm a little bit more of a geek, so I'm more into technology and things like that. And, what I would like to see, or I'm excited about, is how augmented reality, AR, are going to play a role, not after the fact or before the fact, but as you're mapping this patient, all the opportunities, just look at Apple's new, headset, that Vision Pro. I think of all of the things you can do with that while you are in the suite, and all the processing power, analyzing all these images. It can help not just us out, but it can also help level out the field amongst people that may not necessarily do as many of us. Like if you have something kind of guiding you as you go through, helping you understand the images as you acquire them, I think that could be huge. I would just say that's what I would like to see. That's what I'm getting excited about.
Have you guys been seeing anything or talking to anyone who's doing Y90 for organs outside of the liver? Is that in the horizon for you guys by any chance?
Yes, not necessarily for Tyler or I, but as you know, they have a trial going on for GBM, and one of our partners, Paul Clara, who does mainly neuro-IR, is getting involved with that. And I think some of the preliminary results for that have been very promising, and I think that would be great. I know there's another trial looking at prostate, but I'm not very familiar with that, and there could be other applications, right? I think this is what we should borrow. You know, a lot of times people see what we're doing and they try to like apply their techniques to what we do. This is what we should, like mainly radiation oncology, we should do the same, right? Everything that they radiate, we should be able to go after. And I think if you look at it that way, soft tissue sarcomas, a bunch of other things, you know, lung, I think there's an interesting lung, but I think we should be applying it the same way.
Is Paul Galata like the nicest guy? Every time I talk to him,
100%.
super nice dude.
Like he doesn't have a bad bone in his body.
Charade.
He's got some of the worst jokes that you would ever hear, but not a bad bone.
I disagree. I like his jokes.
Not a bad bone. Just no funny bone. All right. To our audience, thank you for listening. If you enjoyed the show, please check out the show notes. We're going to try and include links to the articles that we referenced. Those are going to be found at www.backtable.com. And a big thank you to the people in the BackTable team, the medical students who make those show notes a reality. It's certainly not me, so we appreciate the good work. I think that's where you can find some links to free CME. Last thing, new show, BackTable MSK with Jacob Fleming. If you like the intro music, please let Jacob know. It's all original, written and composed by the good Dr. Fleming. For those others, or for everyone else interested in supporting the show, like, subscribe, and share the podcast on social media. Or if you're an old person, just tell somebody about it. Good old-fashioned word of mouth is very helpful as we continue to build this community that wraps things up. We'll see you next time on the podcast.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dong,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manveer Singh Sabli.
Administrative support provided by Jamila Kinnebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.